All right, welcome to the show. Subscribe at kevinmd.com/podcast. Today we welcome back Pamela Buchanan. She's a family physician, and today's Kevin MD article is How Poor Communication is Killing Patients and Burning Out Doctors. Pamela, welcome back to the show.
Hey, Kevin, thanks for having me. I always enjoy it.
All right, so tell us what your latest article is about.
So, I'm family physician trained, but I've worked in the emergency room the last 15 years. And so, what I noticed is that I'm not quite sure what's going on systemically. I do know that less primary care doctors are available, but many patients come in undereducated or uneducated about their disease processes.
Hmm.
And I find myself quite often in the ER explaining the minutia and the detail of what's going on with them. They completely don't understand. I think they they hear it, and I find it hard to believe that it was explained to them this way. They're like, just take this pill and something's wrong with your liver. But they don't understand like the full gravity of the situation. My most recent one that really sticks out in my mind is an elderly woman who came into the ER, and she had significant metastatic cancer.
Hmm.
And it was not I couldn't see a way but this was curable, many major organs, and she did not look well. She when she came in, she did not look well. And so as I was talking to her and her husband about what was going on, I told her, well, you have cancer. It's lung cancer, but it's also in your liver, it's in your bones, and generally speaking, this is not survivable. And she was shocked. She was shocked, like she'd never heard this before. Like, part of me wants to think that maybe she was just in denial,
Mhm.
but I've seen it more often than not that it's just they don't understand their disease processes. And so I had to give her information about hospice, which I think she should have had that conversation quite some time ago.
And in that particular case that you mentioned, that patient and her family, did they have a primary care physician? And who was taking care of her when she saw you in the emergency department?
She had a primary care physician, she had an oncologist, and she had some radiation. She had multiple touch points in the healthcare system, so I don't know why that realistic conversation never happened. Her husband was taking care of her, and he said, I thought that was what's going on. I thought this was really bad, but nobody really just explained it like you do. And the other thing we have to realize as healthcare professionals is that we're smart people. And so the line I use is I say, I'm going to give it to you in doctor terms so you know the medical terminology. You can write it down if you want to, but then I'm going to talk like a real person.
Hmm.
And I kind of just break it down like you're a 2-year old because I really want you to leave understanding what has happened. That's one instance. And I also see people coming in quite often post-surgically, mainly urological and gynecological surgeries, coming in and saying, a a combination that happens with this surgery is happening, and they didn't have anybody to call. They didn't have an exchange to call. And they're like, well, I had blood in my urine. I was like, yeah, you just had a urological procedure. That's normal. And so now they've wasted an ER visit for that. They spent
Yeah.
5 hours waiting. And, that's not a good experience for anybody. In our hospital system, we have worked to speak with the specialist to try to shore that up and say, we're seeing multiple of your patients after their procedures come in. And we got a nurse navigator to be there to answer those questions. So we stop the ER visits that are not necessary.
So you have the unique perspective of both being a family physician who works in the emergency department. So you get that primary care view, but you also have that emergency department view. So in that first case you talk about, that lady with the hepatocellular carcinoma, can you speculate perhaps on some reasons why her oncologist and primary care physicians may not have given her the prognosis or not made her understand her prognosis? What are some reasons you think could have happened?
I know patients go through denial when something like that happens, but her disease process was so progressed that I just believe someone should have had that just very sincere, deep conversation about what was likely impossible. I always respect people's faith. And, where I'm in the Midwest is the Bible Belt. There's a lot of Christianity. So there's a lot of faith. And I get that. I have a lot of faith too, but sometimes there are just some frank realities. I think, it's time too. I think, I know for primary care, you got 15 minutes. You don't have time. And in the ER, yeah, there's a 5 hour backup, but you work until you get the job done. And I just feel like I have to let the patient know that, hey, this is serious. It's into your bones now. So unlikely, but I think it's probably a time factor.
And you also wrote that the fact that these difficult conversations weren't being had in the primary care setting, that leads to burnout down the line. So talk about the impact it has on you in the emergency department to have some of these conversations in that setting.
So think about, the nature of what an ER doctor does, So we're in that position where there's emergencies coming in, where it is that when the ambulance comes to the door, you hear the tones over the radio, you get ready. It never changes. You can become a big ball of energy, buzzing cortisol levels up, and you're thinking, if this, then that, and if this doesn't work, what if I have a difficult intubation? It's a lot of stress.
Yeah.
And so that in and of itself is stressful. It depends on what kind of ER you work in as to what kinds of stress. If you're in a level one trauma center, then there's all these gunshots and these car accidents. And then if you're in a rural in the community, I'm in a rural in the community, so we have severe cases of and that need specialty that we have to find transfer for and airlift out. And so that's stressful. So I have that stress, the stress of being an ER doctor. So then you add to that the stress of being a primary care doctor, and now I just feel overwhelmed. I do have regulars who come to the ER and they think I'm their doctor.
Hmm.
And I know their history. I had about three of them yesterday when I was working. So such to the fact that that happened, I generally, when it starts to happen that I'm becoming more and more like the primary care doctor and they have a primary, and then I call their primary and try to, arrange care. Let's get them on the books. Let's get them back into the fold.
And how do those conversations go when you talk to their primaries?
They go well. I just think the primary is overwhelmed. I know in my area, they're just overwhelmed and like, oh yeah, I haven't seen him. And then the patients are impatient. You call your doctor and you think my issue needs to be taken care of now. And most of the time it doesn't. And the appointment's maybe 2 weeks from now. And they're like, yeah, I had a patient day before yesterday and she had an issue, it was minor, and she came to the ER. She says, yeah, he couldn't see me until the next day.
Hmm.
And after I saw her, I took care of the thing, it was minor. And I said, okay, now keep the appointment with your primary care. I'm going to call them. And you need that because you're going to need continuity because this one little thing that I did in this snapshot is not enough. This is going to be something that has to be managed over continuity. Your primary care is your quarterback. No team survives without a quarterback.
Now, of course, time is a common factor here, and we've talked about that many times on the podcast, how time is just not valued in our healthcare system, especially in a primary care setting. So, other than giving more time, are there any tips that primary care physicians can ask to prevent these situations from happening? Any questions they should ask their patient? Any tips that you could give?
You know what I'm thinking? You can't make a doctor quickly. I think it's and then these patients need education and they want to appoint a contact, but I don't think it always has to be a doctor. I think we can leverage allied health, nurse navigators, and have everybody working to the full extent of their license when the patient just needs education and reassurance. In our system, we use nurse navigators to keep them from coming to the ER post-operatively. And I think that that's something we need to tap into. That and then things like automated AI systems where we can take care of the simple things that people think they need to come to the ER for.
Now, what about patients themselves, empowering them to do their own research, Googling information? As you know, a lot of health information is available online. Now we have, of course, AI. You mentioned there's ChatGPT where they can certainly just ask it about health information. So, what's your thoughts on that about patients doing their own research? Because it seems like we as a medical profession are falling short in that regard.
It's hit or miss because you and I both know ChatGPT can be wrong. And you and I both know that if you Google one disease process, you might find five or six different answers because there's no regulation. It's not always academic. And so we still have to be there as the healthcare resource to to interpret.
We're talking to Pamela Buchanan. She's a family physician. Her Kevin MD article is How Poor Communication is Killing Patients and Burning Out Doctors. Pamela, let's end as always with some take home messages that you want to leave with the Kevin MD audience.
I think that it's just important that we do as much as we can to empower and educate our patients, all while protecting our own health and self-care. And then I can be reached at drpstrong.com.
Pamela, as always, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.